presentation.
Speak English because my French is not good enough to do a whole conference. So I want to say hello to everybody. Thank Charlie for the kind invitation and for the wonderful location. And I'm really glad to be back here at the Genius Summit for the third time. This is the third time I'm here. So what are we going to talk about today? Today we're going to talk about class 2 correction in growing patients with the Genius system, of course. So we know that since the introduction of a passive self-ligation bracket system, our approach to the treatment of class 2 malocclusion in growing patients has changed a little bit. Thanks to features such as low friction, the use of high-tech wires, early elastics, and occlusal disclusion, we can achieve a degree of sagittal correction that wasn't possible till now with the other traditional edgewise systems without the use of auxiliaries such as, for example, headgears. So now we can treat most of the non-severe class 2 malocclusions without headgears or other auxiliaries. And we know that patients don't like headgears. How does the system work? We all know the fundamental of passive self-ligation. We know that when the passive self-ligation systems enable teeth to move in the path of least resistance, and the bracket essentially becomes a tube in which the flexible nickel-titanium wire can move freely. Disarticulation reduces the contact, freeing dental movement, and can enhances bite opening when required. And the early elastics, another fundamental of passive self-ligation treatment philosophy, allows sagittal and vertical correction from the start of treatment. So let's go clinical with a case. We see this young girl. She's a typical class 2, division 2. As you can see, I'll show you the pictures with some crowding. This is her cephalometric and her panoramic X-ray. And let's see which is her problem list. As we said, we have a class 2, division 2. We can see the typical incisor position. Here's the degree of class 2. We have a deep bite. We have a constricted arch form. We have a slight midline deviation. And we have a moderate crowding in the upper and in the lower arch. Case setup is very important in treatment. It's the moment where we start the treatment. When we set up the case is very, very important for the rest of the treatment. So what do we look at in the case setup? We look at the bracket position and the torque selection. We put the brackets in the middle of the crown, of the clinical crown, because you don't want to intrude or we don't want to extrude the incisors because we want to keep them at that level of intrusion, extrusion. Torque selection, you know that with the Genius system, you can change the torque in the incisors by putting them upside down. So in certain cases, we need negative torque, we can put them upside down. In this case, we don't need to do anything like that, so we put normal torque, we put them the right way up. And then we look at disarticulation. Where will we put the bite turbo, in front or in the back? The case is a little bit high angle, so we decide to put the turbo at the back, the disclusion at the back, even because with the retro-inclined incisors, the turbo would be very high in front and very uncomfortable for the patient. So we decide to start with the disarticulation at the back. Then we have wire selection. We start with a light nickel titanium wire. And early elastics, we put shorties, that means short elastics from the first premolar to the first molar in the lower arch. Then we look at the stop placement. We put the stop in front of the most prominent tooth of the arch, of the upper arch, so in front of the central incisors. So we start the case with, as we said, with an 014 thermal ultra wire from Orthopartner, basketball light elastics, that is 2 ounces, 3/16. And then This is the setup. So now we go through all the stages of treatment. We go through the arch wire sequencing. We know that traditionally with the self-ligating systems, we have the four stages: initial, lights, high-tech, major mechanics, and finishing. But my friend Ephraim Medina and others have changed this sequence to a sequence of 6 stages that we'll go through together now with the patient. So as we said, we start, first stage is alignment, and we go with the light nickel titanium arch wires. So here we go with our O14. We have our disclusion at the back. We have our basketball elastics. Then we go through the second stage after we've changed to O18. Now we are in the second stage that is called leveling stage, and is leveling, and I would say arch development, that is done with O14, O25, and O18, O25. We change our elastics. They're a little bit stronger. We have the ski that is 3 ounces, still made on the shorty, that means from first premolar to first molar. And as you see already at this stage of treatment, the arches have changed completely shape. You can see the incisors have aligned and they've gone forward to a nearly correct torque. Okay, now we're going to the 1825 nickel titanium wire. Our elastics are even a little bit heavier. We go to the kite surf, so we go to 4 ounces. And we don't need disclusion anymore because the bite is opened and we don't have any contact between the teeth and the lower appliance. Torque establishment phase is the 3rd stage of treatment. That means that we got to evaluate if we need extra torque in the case. So this is the moment after the 1825 when we eventually put a pre-torqued arch wire to get more torque if needed. In this case, as you can see, we don't need, because already with the normal arch wires we've achieved the correct torque we need in front, and we still have some overjet to correct the class 2. So we can go directly to the working phase, that is phase number 4. And it's the major mechanics. So we have stainless steel 1925 arch wires on both arches, and we have elastics that at this time are heavy elastics. 6 ounces, ping pong, 5/16, 6 ounce elastics. We go to the stage number 5, that is space closure. So we have to check if there's any space to close in the case. In this case, you can see by the occlusal pictures that there's no space to close, so we don't need to put any chain, elastic chain, or whatever to close the space. So we can go directly to phase number 6, that is detailing and finishing. That can be done with a beta titanium 1925 or 1725. I like to use a very light O14 stainless steel wires because I can do little bends and I can let the teeth come together in intercuspation with light elastics, as you can see in the picture. And I can do little bends. The finishing stage, detailing and finishing, is the time where you can do arch bending. Yeah, and we nearly always have to do a little bit of arch bending at the end of treatment. Here we've done a little anti-rotation on the upper incisor and in the lower lateral incisor. Okay, so this is the case at the end of treatment. We've achieved a good class 1, and everything is as it should be, I think. And this is done only with elastics. So we've corrected this class 2 malocclusion with the use of elastics. Here she is. Here's her smile, a nice broad archwise, typical passive self-ligation genius smile, broad. The profile, you see even the inclination of the incisors on the smile of the profile. That looks much better in the mouth than on the cephalometric X-ray. So from here to here, this is to show beginning to the end, beginning and end, the smile at the end. Okay. So we know that not all class 2 cases can be treated with this approach, of course. More severe skeletal occlusions, malocclusions, will need something more. Now, we use, typically with children, we use functional therapy in late mixed dentition to intercept the malocclusion at a time when the patients are usually willing to wear removable appliance. So even if it would be better to start at the puberal stage for best results with functional, usually we start earlier because the patients are more willing to wear the appliances. And parents usually want the children to be treated earlier. What we usually is a twin block. This is my functional appliance of choice, but there are many others. Let's see a case. This is a little girl. You can see she has a typical class 2, low angle class 2. You see overjet. She has a functional habit. She impinges the lower lip. And of course, she sucks her thumb, I think. I can't remember. A big overjet, a big overbite, some crowding. You can see the cephalometric. You can see the angle. And you can see the problem at the dental level. Twin block, we all know how it works. It's a system that puts the mandible in a forward position. It keeps the mandible in a forward position for about a year. And this gives a changement that is dental and skeletal. Here it is, maybe we all know about the twin block. And this is what we achieved at the end of the first phase with twin block. We changed the case into a class 1. There's still deep bite, and there's still a little bit of overjet with pro-inclined incisors. So then we can, this is what we see in the face. This is the changement we achieved. Now we go to our self-ligating system to finish the case. This is treated with the Pitt's philosophy, so I put the brackets very high on the teeth in way to extrude a little bit the incisors to help the smile arc, to get a better smile arc. And I put the brackets upside down on the incisors. I changed the torque completely to help change the inclination of the incisors. It's done with the Pitt system, but you can do it exactly the same with Genius, maybe even better because of the quality of the bracket. So this is the case at the end. Finished. You see how we changed the inclination of the upper incisors by changing the inclination. You see the incisor a little bit extruded because in this case you've got to try to keep the smile arc, the smile design as evident as possible, to not make the face look old in advance. You see the change in the torque due to putting the brackets upside down. As we know, activators work only with good growers. We can't expect good facial results with the nightmare, what we call the nightmare high-angle patients. Let's see one of them. Activators will, as we said, work only with good growers, but that doesn't mean that we don't use functional therapy in these cases, because they can help us get at least a good occlusion and straightened teeth. Here's the case. You can see, look at the face. This is in a relaxed, with his lips in relaxed position, thing that is very difficult for him to do. This is the smile. This is the occlusion. You see it's a full unit class 2, crowded. And look at the cephalometric. So this is a very, very unpleasant case. It's what we call the nightmare class 2 high angle, 37 degrees. So the only appliance I can think of in a case like this is the acrylic splint herbs that was introduced to me by my friend Dr. Schiavoni, who is an authority in the field of herbs treatment in Europe. And of course, Dr. Panchas, who is I would say, the reinventor of the appliance. Here it is. This is the case, what we achieved with the first phase. You can see that maybe we could have done more, but unfortunately what happens is the patients don't wear the appliances as much as they should, but in any case, we managed to get this. Then we put our Genius system, our passive cytoligation appliance, and we work to finish the occlusion We wear light elastics. We are very careful to not extrude the back teeth, so we don't put class 2 elastics to the back teeth. Of course, the disclusion is posterior on the molars, on the first molars. Unfortunately, towards the end of treatment, I need to put a bit of class 2 elastics to finish correcting the class 2 that had a little bit gone back. And this is the case at the end of treatment. So the arch forms are quite okay. Let's say the dental side of the case is quite nice. Unfortunately, the face has no change. But as I said, we couldn't even expect change. What we try to do with the herbs is to anti-rotate a little bit the mandible, and mainly we try to move the teeth, the upper teeth, backwards to get space and to correct the class 1 without extruding. So let's say that the fact of maintaining the same angle without opening the angle is already a good result in these cases. Maybe we could have done better if we put a high pull headgear on the herbs to help more intrusion during treatment. In permanent dentition, what do? We use the Herbst appliance or Herbst derivated appliances such as the Forsus, the famous Forsus. This is a case I showed you 3 years ago when I came the first time. I showed very quickly again for who didn't see it, just to show you what you can do with this appliance, with the Herbst and Herbst derivated appliances. This was a very severe class 2 in a patient at the end of growth with severe retrusion and severe crowding. And he had the roots of the incisors that were completely reabsorbed by a previous orthodontic treatment. So what we do, we align the teeth, we create an overjet, we align the teeth and we create overjet. As I was saying, we put our Forsus, and this is what we can achieve at the end of treatment after the Forsus treatment. Forsus or other similar, we have similar appliances to Forsus. Okay, so even the incisors are still in the mouth, as we say, luckily. Of course, we have to ask ourselves if this is a skeletal or a dental result. This is a discussion that goes on for many years, has been going on, and if the Herbst gives a dental or skeletal result. Dental for sure, skeletal maybe a bit, I would say a bit and a bit, but you can see the change in the face is very important. Skeletal or dental, but it's a big change and it's a nice change. And it's stable in time. The guy is growing and his teeth are still there in a good position. Now this is a tough case. I want to show you, I want to share with you, it's a case that I just finished and I wanted to share it with you. It's another of those nightmare class 2 high angle. Here she is. As you can see, severe class 2, cross bites, blocked out canines, pro-inclined incisors, low incisors. Cephalometric, as you can see, she's a high angle too. This is a case that would have needed the approach that we used with the previous case, high angle case. But for a reason or another, I didn't use that appliance because I didn't trust the patient on her cooperation, and I didn't want to do the expansion before and then put the herbs. So I used an appliance that did the two things together. That is the Crossbow Appliance by Dr. Higgins. I don't know who of you knows it. It's a derivative of the Herbst Forsus. It's made by a Hyrax expander in the upper arch and a double lingual arch, lingual and vestibular, where you attach the Forsus, and the effect is the typical Forsus effect. And this is what I used in this patient. Here she is with the appliance on. She has a screw to do the expansion, the rapid expansion, and at the same time she's pushing forward. There she is. We can reactivate the forces a bit. Look, the forces is pushing. And this is her at the end of the phase of the forces of the crossbow. It's scary because you think, am I going to get these, am I going to close the bites? Am I going to get those incisors back again? So we put on our Genius appliance, light, very light wires. We've got to go very slowly. We wear elastics, very light elastics in the front. Of course, we don't want to extrude the back. Then when we go ahead, we have to use some class 2, because as you see, the class 2 is coming back, even if we pushed it into class 3. So we use all our elastics in all the different fashions to try to correct class 2 while we're closing the bite. And this is the end of treatment. I just took her the appliance off the other day, so you can see she's still, the teeth are not, the gums are still swollen. It's not perfect, but I think it's the best I could do. And she wanted the appliance off because of the wedding of her sister, and I wanted it off to come to show it here. So we removed it. Here she is. This is a cephalometric. This is from the beginning to the end. You see, we didn't do much to change the facial axis, because in high-angle cases it's practically impossible. But we managed to keep the angle the angle didn't grow, and we managed to keep the incisors at a good angle. They didn't go prinkly too much. To finish, just 2 words on an appliance that is gaining a lot of popularity. That is the Courier Motion. That is, I started using quite recently. Maybe you know how it's a kind of a jig on the upper arch with a hinge on the molar to derotate. That works with class 2 elastics on a lower appliance. It can be a lingual arch or an Essex retainer. This is the one with the Essex retainer. Just very quickly, 2 cases that have started. This is a typical case where you don't have a big class to correct, but you need a lot of space in front. So it's very good for the Courier. There, the Courier is on with the heavy elastics. This is how it looks in the mouth. She has an Essex retainer and 2 tubes on the molars. And you see what happens in 4 or 5 months. You've got to be very careful when you go to the fixed appliance, to the self-ligating appliance, to wear light elastics or to do a lace back on the canine, because otherwise it will rebound into class 2 because of the inclination of the slot. This is another one she has very pro-inclined incisor, low incisors, so you know that for class 2 correction that's very bad. But we decided to put the Courier the same. Here you can see how it works. Look at the pro-inclination of the lower incisors. But if you work well with your rectangular wires and you help yourself with a chain from canine to canine on the lower incisors with rectangular wires, you can control this pro-inclination quite well. They're all cases that have just started, but I hope and I think they'll go quite well. But there are other auxiliaries. Some are good, some less. It all depends on our skill or preference. We have many to try. We can choose. And what about the future of class 2 treatment in growing patients? I think that TADs are going to be more and more widely used. And I've seen cases treated by Dr. Park from Korea with mandibular anterior rotation obtained by lower molar intrusion with the use of TADs. And that I find is exciting, and I think we're going to move more and more in that direction. For now, I want to thank you and pass the word to the next one. Thank you.